Good afternoon. I am presenting today on behalf of Medicine 3. My topic for today is Jontronas, the pain. I am presenting as a case series of 3 cases. So case 1 is a 65-year-old female presented with low back pain for 1 month with heaviness of numbness of bilateral lower limbs. So 1 month ago had fever, went to a local hospital and diagnosed as pneumonia, is MRSA pneumonia and treated with antibiotics. Then he started having back pain, which was more severe for the last 10 days. His vitals are stable, temperature is 100 degrees, and general examination is pallor is present. Systemic examination wise, CNS, motor, bulk and tone is normal. Power upper limb is 5 by 5. Lower limb is initially 3 by 5, which then worsened to 0 by 5. Reflex is knee and ankle jerk are absent. Plantar is bilateralis flexor. Anal tone is decreased and voluntary anal contraction is absent. So the initial investigations, HB of 8.37, all other blood parameters.
After the clinical scenario should give us some differential diagnosis or a clinical impression before proceeding to investigations. What do you think is the clinical diagnosis at the end of your history and exam?
MRSA induced septicemia, which has progressed to involve, which is seeded into the bone.
So what is that? Just bone?
An abscess is formed.
Okay. An abscess. What is it causing?
It causing a infective spondylolisthesis.
Okay. Has it produced any neurological deficit?
Yes, sir.
So why?
It's a paraplegia.
Where do you localize it?
It's a T9 to T10, this patient.
T9 to T10? I mean, it's always advisable to put in the clinical impression and then follow it up with investigations. Okay, proceed.
So culture and sensitivity sputum was done, which showed Staphylococcus aureus is positive, and blood culture also done, which is also showed a MRSA, Staphylococcus aureus. So coming to the second case, it's a 70-year-old male presented with fever for 2 months, with rash for 2 months, associated with throat pains and joint pain, more in the right knee joint, and associated with low back pain. There is no history of dysphagia or dysphonia. Past history-wise, no comorbidities. It's a non-smoker or alcoholic. No normal bowel diabetes. So vitals, temperature is 102 Fahrenheit. Systemic examination-wise, normal findings. No particular systemic findings. The differentials here consider it could be an autoimmune or an infections or a probable. So this initial investigation showed a total counts of leukocytosis with elevated WBCs. So HB hemoglobin of 12.7, normal hemoglobin with normal urine creatinine values. Is ANA, ASO, and autoimmune workers are all negative. Rheumatoid arthritis, rheumatic factor, and anti-CCP are also negative. And the CSF was done, which is also negative, and bone marrow is done, which is also shows a normal pattern. So the third case is a 76-year-old female presented with a low back ache for 1 month, non-radiating, more severe during the night. There's no sensory motor weakness, no bowel or bladder incontinence, no history of fever. So she is a diabetic and metformin and glycoside and hypertensive. Vitals are stable, and general examination wise, pallor is present. Systemic examination wise, bilateral knee and ankle reflexes absent, and scoliosis is present with diffuse spinal tenderness. Her investigation showed a HB of 7.1 with the elevated urea creatinine renal dysfunctions with an age reversal of protein of 10 and albumin of 2.3. So all the 3 case series, the patients presented, one of the presenting complaints were a low back pain. So today my topic is approach to low back pain. So the causes of low back pain could be the injuries, say inflammatory, cancer, metastasis. It could be a mechanical or osteoporosis. So the common etiological causes we generally see is mechanical is 50% more common, which is due to poor posture or pregnancies and occupational related. Degenerative joint diseases 15%. In that, lumbar spondylosis accounts for around 10%, and 3% diagnosis. Post-traumatic is 10%. Acquired causes like inflammatory arthritis, infections are 2%. Malignancy 1%, which could be a multiple myeloma, leukemia, or other metastasis like carcinoma, prostate, breast, or ovaries. And psychogenic causes also includes a 15%, so anxiety, depression, and fibromyalgia. So whenever we see a patient in OPD who came with low back pain, we should look for the red flag signs which could indicate some other underlying disease. The onset of age less than 20 years or more than 55 years. So non-mechanical pain which is unrelated to time and activity. So associated with any previous history of carcinomas or family history of malignancies, any steroid use, or any weight loss, or any neurological symptoms. And if the duration is more than 6 weeks, which could be an indicator any tumor or infection or rheumatological disorders. Fever, chills, and night sweats, which could also favor in tumors or infections. Injection drug use or immunocompromised states, and night pains, which could also be a indicator for tumors and infections, and urinary incontinence in. So approach is a history and examinations, the age, the durations, occupation, or the risk factors, and any neurodeficiencies and psychological factors are present. So we have to look for the red flag signs. If in case of there is no red flag signs, then we can advise a physiotherapy, analgesics, and NSAIDs, and we have to reassess the patient after 6 weeks. So in case any red flag signs are present, we have to proceed with further evaluations of CBC, X-rays, bone scans, and serum electrophoresis in case needed, if needed, warranted CT or MRI or EMG, NVE. And based on the results, we have to look for the underlying cause and treat the underlying cause. If in case of no red flag signs and even after 6 weeks of physiotherapy and analgesics, the patient persists to have these symptoms, we should consider any underlying cause and we should further evaluate it. So there's a study in which Finland shows a suicide among persons with back pain. In this study, out of 2,310, 490, around 25% had a low back pain, which is not directly even though contributed, but it could also be one of the contributing factors, which is that. So the case one is an MRSA septicemia. The MRI was done, we showed T910 infective spondylodiscitis with anterior epidural abscess. So we started him on injection vancomycin 1 gram BD, and emergency T910 debridement with decompression and fusion was done. So the second case is a case of adult onset still disease. It is a diagnosis of exclusion. Here we excluded the autoimmune component, the ASA, ANE, rheumatic factors, ASO, everything was negative. The infection component also ruled out, the counts normal. The CSF was also done, which is also normal, and the malignancy part was also ruled out. So it is the criteria for adult onset still disease is Yamaguchi criteria. The major is at least two of the major should be present. A fever of at least 39 degrees Celsius for at least a week. Our patient had a fever history for around 2 months, and arthralgia, arthritis for at least 2 weeks. He had this right knee joint pain, and non-pruritic salmon color rash or trunks or extremities. He has the history of rash for 2 weeks, and granulocytic leukocytosis. In our patient, the leukocytes are 22,000, and he also had this minor criteria of sore throat and negative test for rheumatic fever and ANE. So he fulfilled the Yamaguchi criteria. So he was diagnosed as adult onset still disease, and he was treated with NSAIDs and methotrexate. So the case 3 is still under evaluation. Her investigation showed a elevated calcium with renal dysfunction with anemia, TSG reversal. The bone marrow is done, which is report is awaited, and the multiple myeloma workup is being sent and is still awaited. So the rolling points is the approach to the low back pain. Whenever you see a patient in OPD with low back pains, which is commonly we are seeing, if there is, you have to look for any red flag signs. If there is a red flag sign, we should assess the patient and look for any underlying causes. Thank you.
Thank you, Dr. Rajesh. Any questions from the audience? One suggestion: with every case, I would suggest that you list out your differentials and then justify the investigations, because otherwise we'll be left wondering why suddenly CSF, bone marrow for this patient. You should, if you had written the differentials and for that be evaluated with these investigations, that would improve the clarity of your presentation. By that way, you will also be able to insist on your learning point as well. No questions. Thank you, Dr. Rajesh. And we'll move on to the third presentation from Medicine 2 by Dr. Ritesh Ratnakaran on the topic hot and knobby.